So this is our third session, and before we dive into it, it is 3 o'clock on a Wednesday. So I just want to also quickly check in with everybody, how everyone is doing. You can use the chat box to put in a word, one word. Don't think about it too much. That describes your current feeling state. Uh, could be tired, could be sleepy, could be happy, could be anything. I just want to get a sense of what's going on in the room, because 3 o'clock in the afternoon is not a great time to study. Well fed, Shruti, I'm really worried about that, because well fed also means sleepy. For me, it means sleepy. All right. I'm not gonna be the usual dictator that I am and ask everyone to turn on their cameras, although it'll be nice if you do. But all right, so curious, good, tired, but happy to participate, well fed. Okay, keep them coming. It's always nice to know, I find that these Zoom meetings are very dehumanizing. And this is one way of feeling cold. So am I. I'm in UP and I'm freezing. So at least we know what we're contending with. And I think these kind of quick check-ins also help us get to know each other at a, like a snapshot. All right. By and large, a positive room. The ones that are not responding, I'm really worried that you're sleeping under a warm blanket, especially if you're in North India where I am. Okay. So we're going to talk to you today about essentials of good practice. This is by no means to assume that we know better. I know there are some of you who've been doing this for decades and years and are doing it very well. There are people who do it on a daily basis, whereas somebody like me, it's been a long time since I've had a face-to-face patient interaction or a family interaction. I do work with families over the phone and over Zoom to help them navigate some difficult conversations. But there are people in this room who are far more experienced than I am when it comes down to understanding what it means to do a good assessment. I invite those of you who are well-versed in this art to please share your experiences. I will pause from time to time and I lean on you to share your experiences with us. This is purely from the perspective of what we find has been helpful over the last many years. Psychosocial care in palliative care as a separate discipline is not very old. Palliative care itself is not very old. It started in 1967 in its formal capacity in St. Christopher's Hospice in the UK. And it came to India years later. The first palliative care service was started in Bombay. And of course, many others have come up now. But the focus, I mean, we are fighting an uphill battle. We're trying to figure out palliative medicine as something that should be taught in the medical curriculum. But psychosocial care and palliative care has largely been done by people who are interested in providing this kind of service, people who are volunteers, people who are counselors. When I got into palliative care, there weren't a lot of other psychologists in it. There were certainly not a lot of other counselors in it. And so we've had to feel our way through the dark. Having said that, it is also a field where psychosocial care is not just important, it is vital and essential. And in order to provide the right care, you have to ask the right questions. And I think that is the same, whether it's the science of medicine or the art of counseling and therapy. So you need to know where to begin in order to make competent and compassionate decisions. You need to know where the person in front of you is, rather than make assumptions about it. So what we're here to talk about today might seem very familiar and very obvious to some of you, but it's just a chance for us to sharpen our understanding. Maybe some of you have experiences that might be counter to what we're talking about, and I'm really happy to hear about that as well. So let's just start with I strongly believe that if it's only when you lay the foundation that you can build a strong house on it. And while we might imagine that the medical part of palliative care is the most important part, I sincerely believe that it's the psychosocial aspect of care that really underlines and underscores all the care that we can provide, even medical care. So, sorry, I can put the mics on, Senia. Okay, then. like last time, I will encourage you to please put in your questions, comments, reflections in the chat box. I will pause from time to time. Senior and Deepa, if you see something that is an important question that I'm missing, please stop me and, refocus my attention to that question and I'll take it. And I will also request, like the last time, if you have anything personal in terms of some, difficult experience that you've had, let's save that for later so that we can give it the attention that it needs. All right. So we talked about this last time, total pain, where we say that the physical pain reported by a patient is compounded by his or her life circumstances. We did a little thought experiment around that, if you remember. And just to, reiterate the fact that that little thought experiment was a tiny little dot in the ocean of the kind of pain that people experience when they're going through serious illness. I would also like to highlight the aspect of social diagnosis, where in order to understand somebody's distress, it's important for us to understand their psychological, biological, social, and environmental factors that are operating on the person in his situation. Now, it's not just financial burden or the physical pain or distress. There are lots of other factors that are moving around in, in lockstep in that sense, as the person navigates their journey of illness, and all of these different things, whether it's their biological changes that they're going through, whether the social impact their illness has, all of these different factors have an impact on the person's total pain or experience of total pain. And let me just ask you a question here, right? We say, okay, let me stop for a second. Do you all believe that there's a difference between the words disease and illness? And if yes, I'd love to hear from you. If there is a difference to you, what? Please just feel free to.
So, ma'am.
Yes, Priyanka, go on.
So I have an impression when I hear the word disease is that it seems temporary and curable and easier. But when I hear the term illness, it feels more severe. I mean, just the feeling I'm getting.
Okay, thanks, Priyanka. I see that people in the chat box have also said that, yes, there is a difference. Shweta, anybody else? What do you see as the difference between disease and illness? We use these terms interchangeably when we're talking about illness or disease, right? So sometimes we use the word
the patient may not have disease, but may be ill, because there are so many important factors regarding illness. It may be psychological, or it may not be associated with the disease.
Okay, all right. So there can be one without the other. Anything else? Diseases
are ill because of the disease.
Go on, please.
Yeah, we are ill because of the disease. Disease is some, I don't know. It's an illness, but then like it has a name and everything. Illness is we feel something that we feel, something we experience.
Right. Okay, great. Fine. Wonderful. So diseases have fixed etiology. Ill is from the feeling of someone who has a disease. Okay, great. I think we're warming up to, we're coming to what the difference really is. So here is the difference. The disease is an abnormal condition affecting an organism requiring treatment. Infections, diseases like degeneration of the tissue, injury, trauma, toxic exposure, these are all factors that contribute to a disease. Okay, so it's an abnormal condition clearly affecting an organism or an organ system requiring treatment. Okay, that's disease. Illness, on the other hand, are the emotions, the distress, the discomfort, the fatigue, the weakness, the dysfunction, the pain that requires management. Okay, are we clear? So disease is the organic biological condition, abnormality. The illness is everything that stems from it, the difficult emotions, all of these things that are on your screen at the moment. And treatment and management are two different things. Okay, now there is a relationship between the two, as some of you have pointed out. Disease usually causes illness. Somebody said that in our group today. Okay, but A person with a disease at times may not experience an illness. That also somebody has said here, that you can have one without the other. For example, you can be on medication for high BP and not actually have the like you might not be emotionally distressed by it, right? You're taking your pills, you're managing your BP, it's under control. And it's not causing you any great distress unless you miss out on the medication, and then you need some management there. Early stages of cancer. Why do so many people present so late with cancer? It's because early stages do not actually have symptoms that cause you distress. So you could be living with the disease and not know it. So that is also a possibility. Yeah. However, there are also illnesses without diseases. We call them somatoform disorders. And this actually really stems from a lack of understanding of the biological basis. I do not know why this person is feeling this way. It's all in their head. So you've heard this? It's psychosomatic, somatoform disorders. This doesn't really exist. It's in the person's head. I would like to underline here that this is a topic of hot debate. There's a whole bunch of us that believe that the mind and body are very deeply intertwined and connected. What happens in the mind does have somatic manifestations. Just because we do not understand it in a biological sense, or our science is limited in that capacity, does not mean there's no connection between the two. I'm not getting into what I believe in this case. We're just going to leave it as a topic of debate. There are people who believe, either or. All right. So the other thing is the way a person experiences it, the illness, does impact the disease. My fatigue might stop me from going to my hospital consultations. I might be too emotionally distressed to comply with my medication. My emotions might drive my caregiver away from me. And therefore I'm left alone, and my disease gets worse. My own pain prevents me from eating healthy food, which is something I need in order to get better. So illness also impacts the disease in return, okay? And Eric Cassell said this. He said, disease then is something that an organ has. Illness is something that I would say a human has. I mean, that's a very masculine way of putting it, but illness is something that a human being has, okay? But here we are, we must address the disease and the illness. If we want to get people to feel better, you cannot just treat the disease, you have to treat the illness. And with the illness comes all the attending emotions, all the attending dynamics between human relationships that are at play. So this is why psychosocial care is so important in palliative care, because living with a life-limiting or a life-threatening illness, or even the awareness of approaching death, causes very unique stressors and challenges. There are things that people experience when they're going through this journey that no other journey in their lives will ever bring them face to face with. When you are sick, when you are a caregiver, when you are having to make every decision in your life based on your biological status, on your disease status, it is a very, very unique set of stressors that you experience. Decisions about where the household resources will go, where the money will go, who gets to work, who doesn't get to work. All of these are determined by the disease and the illness. And so it's a very unique set of stressors and challenges that cannot be wished away. They have to be addressed very separately. And a serious illness disrupts the individual's thoughts and feelings, their relationships, social and spiritual supports, as well as their financial stability and sense of spirituality. We've talked about this, right? So anyone with a serious illness, there is not a single domain in their life that is not impacted. Everything is impacted. You cannot compartmentalize your illness and your disease from the rest of your life. And which is why all the more psychosocial care is absolutely essential in the provision of not just palliative care, I believe, but also in the provision of good healthcare. So let's look at a case study, and we're going to be looking at this case study in a little bit more detail towards the end of this session. One of our social officers will be presenting it in more detail. But for the moment, I'm just going to present the overall picture. Okay. So a 55-year-old lady diagnosed with cancer of the buccal mucosa has been referred to you after receiving radiotherapy and chemotherapy at the Regional Cancer Center from 2021 onwards. She is accompanied by her husband and son. She is in pain, she's emaciated and undernourished, and she is nauseated. This is what she's telling you she has. All three of them, the lady, her husband, as well as her son, appear very emotionally low and distressed. I'm going to read through this one more time, okay? 55-year-old lady with a diagnosis of cancer of the buccal mucosa has been referred to you after receiving radiotherapy and chemotherapy at the RCC. She is accompanied by her husband and son. She's in pain, she's emaciated, nauseated. All three of them appear to be quite emotionally distressed or low. So I'm going to stop here and I'm going to check with you. Now, where will you start? If you're going to be assessing this family and if you're going to look at total pain, what are some of the immediate questions that you're going to ask them? Or what are you going to do? Just what does assessment look like? Or what does the foundation look like at this point? What do you want to know about this family? Please feel free to just use the chat box. We're going to spend a couple of minutes here and I want to hear from others in this group. I know there's many counselors here. There's about 70 odd people here who worked with people living with HIV. But let's also take our experiences from other areas we might have expertise in and try and apply it here. Background first. Yeah, Geeta. So what in the background? Financial background. Okay. So I want specific questions. Yes, can we get specific questions? How much does the patient know about her condition? We would like to hear from them about their financial condition. Okay. Since how long has she been having symptoms? I will manage the pain first and after that explain then what happens. Okay. Dislocation of place. Dislocation of place. Harpreet, can you explain that a little bit more? I'd like you all to frame questions that are emerging for you, okay? Rather than saying, let's explore the background, tell me what the question is that you will ask to explore the background that you want to know more about. Anxiety, okay, so how will you explore the anxiety level of son and husband, please? Gopa. What all have you tried in the past that has helped you with the pain? Excellent question. Excellent question. What has helped? What does treatment currently involve for the recipient and caregivers? Kind of treatment, context, roles of caregivers. Very good. What do you think has happened to your loved one? That's a question for the caregiver. Yeah. All right. Okay, let me also ask for physical symptoms of the caregivers. Excellent. The caregivers are often invisible patients. We call them invisible patients. Okay. Assess for depression. Okay. We're going right into the heart of it. At first, you're going to have to build rapport with this lady, right? She's not going to tell you a lot of this stuff unless you've actually struck up. I would say, please start with introducing yourself. Very often, one of the biggest problems in our system is that, a patient and their family walks in, somebody in a white coat or looking official comes and asks them a bunch of questions sitting with a little form or like a checklist. I have no idea who that person is who's asking me all these personal questions. So first and foremost, and you are going to have classes on communication. So I'm not going to belabor this point, but firstly, introduce yourself. Tell them who you are. Who in the team are you? And I would say start with asking their name. We tend to dehumanize patients and families in healthcare. They are known by case numbers and their diseases. There are people in our team who, and I know Ashla has used this as an example, so I'm going to say it. Ashla, who is Dr. Raj's executive assistant, as well as one of the trustees of Pallium, has been a wheelchair user and a care recipient for many years now. And she tells us of the time that when she came to Pallium India was the first time somebody asked her mother her name. It goes a long way. Who are the protagonists of the story that you want to take care of? It's not just the patient, it's a person who's standing beside the patient as well. And I'm really glad to see that some of you have, pointed that out. But really, the one of the biggest problems with our system today is the utter lack of information that is given to patients and their families, right down from the basics of who am I talking to you. Sorry, the power is gone. But okay, the fact that the person standing in front of you, what role do they play in the healthcare system? How are they going to be talking to you or accompanying you on their journey, on your journey? What are some of the bits of information that you have not been given yet? Who is going to give you that information? So lack of information is a huge problem in our current service delivery system. And I would say start with that. Okay. Coming back to the slides. Okay, so we've sort of warmed up to this. Anything else? What else would you ask? Make them feel we're listening to them. Yes. Think about total pain. Remember what I said, total pain. Okay, now assuming we have established rapport, they know who we are. We know a little bit about their, basic information. In your mind, if you're making a checklist of things that you're going to explore, what would this is not necessarily stuff that you're going to ask them immediately, but if you were to make a checklist of things in your mind of what you want to start looking at to understand this family story better, what are some of the things that you're going to make a checklist of? So some of you have said financial background, right? So that's one quadrant of the checklist. What else? How you discovered your problem. Okay, that's going into the history. What is your current condition how is your current condition affecting your activities of daily living? ADL is activities of daily living, for those of you who are unfamiliar with that. History taking, when did it start? Social support, excellent. You have to know what their social support system looks like. How is the patient feeling? Family members, previous illness, where were you treated? Okay. All right. Now, I'd like you to make a note of this, that when exploring, assessment is an exploration. Okay, you're exploring, and it's a process of gathering information about the person. Now, all of you have talked about the different bits of information that you want to put together in a jigsaw puzzle. And what you put together in that jigsaw puzzle will help you determine how you can help this family. So the questions you're asking them, the information that you're gathering is not random bits of information. You are asking specific questions in order to be able to help them, right? So it's what we call purposeful. And inaccurate or incomplete assessment will lead to inappropriate goals and interventions. If I do not have the information that I need, if I don't have information that is relevant, my interventions and the ways in which I will be able to help that family will also be hampered. Now, asking for information, again, it's not just getting as much information as possible. There has to be a purpose behind that. There has to be a purpose behind the question you're asking. Let's not waste their time by asking for a major family history if that family history does not have a bearing on how you can help this person. And the thing is, we can, in this moment, now let me give you an example. Now, someone has come to you in excruciating pain. She's nauseated. She's really struggling with, her own emotional distress. Do we really want to go into the history of her illness and how she first came into how did she realize what her symptoms were? Where did she go? Is that really important in this moment? Or can it be postponed till a time when she's been made more comfortable? Okay, no, yeah. So in this scenario where someone is coming to you presenting with extreme pain, what are the questions you will direct to her as well as to her caregivers? In order to treat pain, you need to also ask questions. We can't just jump in and give them medication, right? So we need to also ask specific questions to help us treat the pain. We can relieve them from pain once We understand where their pain is, the severity of their pain, what triggers the pain more, what lessens the pain, how long has she had it, what has she taken for it before, what has helped, what has not helped. These are the questions that are purposeful. They are the questions that are going to help us make a more competent intervention later. Now, assuming that this person the pain has been controlled and she's much more relaxed. Now, what will you ask this person? Pain is under control. She's much more relaxed. Now, what is your conversation going to look like after this?
Maybe you can ask them how they feel, how their mood has been for the past 2 weeks, assess for depression, anxiety, because these are very common conditions in palliative care, and effects of treatment, and what all, like supposing it hurts again, then what they can do, what helped this time probably will help next time, and how their family is taking it, and getting to know the patient. Assessment is usually a very continuous process, so keep assessing rather than just diving into treatment. So you formulate the case throughout the session.
Thank you, Isha. That's really helpful. Just as you would treat the pain first and then come to this, you also have to, like Isha said, you have to formulate. You can't just keep asking. It's not a word association game. You are exploring certain things with a specific reason why. Okay. And you have to plan your conversations. You can't just go in and say, okay, let's see what comes up today. It's not that. You have to go and say, okay, first thing I'm going to ask is, how is your pain today? Because that's what we treated last, right? And then we're going to get into, okay, tell us a little bit about your journey. Tell us how you got to us. Tell us what you know about your illness, those kind of things. But be very clear in your mind where these bits of information that you're gathering is going to fit into your goals of care. Okay. And I love that Saima, what Saima has said. What are her expectations? What is this lady's expectation coming here? And you'll find that different people say different things, right? Some people say, I don't know, my doctor just sent me here. I don't know. The doctor told me to come here, so I came here. So then you have to help her arrive at what her expectations are. And it's not telling her what her expectation should be. It's helping her understand what we do here, etc. But in order to not get it wrong, we also need to know how much she knows. Our expectation can only be, we have expectations of things once we have information about it, right? In the absence of information, how can people have realistic expectations? So we need to take a step back and say, what does this person understand about his or her illness? Okay. Here. Now, what is the aim of assessment? Now, backtracking a little bit. Sorry, I'm a little bit distracted by the chat box. First of all, we have to identify factors and interventions that may influence the well-being of the patient and the family. We're not just here to treat the disease. We're here to manage the illness as a whole. And illness has many aspects to it, as we know, and the overall well-being of the patient and the family is what we're trying to maintain. And now, in some cases, for example, sorry, this slide is not relevant here. Now, who are our sources of information? Okay, we have the patient and the caregiver, but we also have collateral sources like friends, relatives, neighbors, and a very, very important aspect of a very important source of information are home visits. Now, what we're trying to do in putting together the story of this patient and the family and how we can manage them best or help them best is we're trying to get a picture, the snapshot of their total pain experience. The patient may at times not be able to give us the full picture, either because they're in so much pain, or the patient is not conscious, or the patient has delirium, or the patient is just withdrawn and doesn't want to talk to you, at which point you will talk to the caregiver. Now, Caregivers also, there are different kinds of caregivers. You have the primary caregiver, the caregiver who is at the bedside, providing all the direct care to the patient. There are two kinds of care. One is direct, one is indirect. Direct care is everything that I do for the patient, or not, sorry, do to the patient, bathe them, feed them, help them use the toilet, clean them, things that their activities of daily living, transfer them from the bed to the wheelchair, transfer them to the toilet seat. All of those things are direct care. Indirect care is things that I do for the patient. Go to the bank, pull out money, apply for a loan, drop their children to school, things like that. That is how I'm providing indirect care. I might walk their dog, take them for a walk. I might cook food and bring it across to the house. This is all indirect care. Now, so who is the caregiver that you're going to talk to? You will also find very often that the primary caregiver is often a very disempowered member of the family. They are not the ones making the decisions. The person at the bedside could be the youngest daughter-in-law. It could be an unwed sister. It could be it is usually a dependent member of the family who does not have the wherewithal to make decisions that are more financial in nature. So the information that you are going to get from the caregiver is information that you will get about the day-to-day care of the patient, the primary caregiver. Sometimes that person is also the financial decision maker. There's no doubt about it. But please know who you are talking to. Very often it is the person who is paying the bills that is deciding the care of the patient. That person could be somebody living in Dubai. It could be a son or a daughter living in the States who is sending across money. It may not be the person who is actually at the bedside of the patient. I'm going to stop for a second and collect some of the thoughts and responses from all of you. Is this making sense? We tend to call them caregivers, but there are categories or there's nuances in the differences between people who are providing this care. So any thoughts on this from anybody who has had any experience? Or have you found, is there a story that any of you have to share that, you find that there's a difference in what the caregiver is telling you and what maybe the patient is saying or somebody else is saying?
Yeah.
Yes, Geeta.
I have a 91 and a half year old mother-in-law living with me now, and she has a caregiver because I couldn't manage since last 10 months. But what I found out after my husband passed away, and I've been trying to spend some time, is we depend on the caregiver so much. And though I live next door to each other, but lately I've been finding that you don't get all the information. Things have changed.
Sorry, you're muted, Geeta. Senior, can you please?
Yeah, okay. So we depend on the caregiver thinking that they are providing the care because we're giving them money, we're giving them. But the actual truth that I've been finding out lately that there's been so much hidden from me. Like she's been sneaking out of the house, putting her to bed. Right now, in fact, she's done that. So like I got my phone here, I've put mom to bed. And I said, if you have to call me. So what I'm trying to say is we think we made the provisions for the caregiver. She's okay. In front of you, she looks after you, them very well. But when you're away from them, you don't know what's happening.
Yeah.
So you don't get, like you said, you may get the information, but you do not get all the information from them.
Absolutely. Yeah, absolutely.
We can't depend on that information 100%.
And that's a great point, because it's I'd also like to take that a step forward and say that information that you get from anybody is subjective information. Whether it's from the caregiver, whether it's from a hired caregiver or a family caregiver, whether it's the sibling that is sitting in Dubai sending money, whether it is the patient themselves. You will only get one side of the snapshot, which is why it's really important, if you want to be of help here, to really get as much information from as many sources as possible. It's not always possible. Now, for instance, family conflict. A huge source of distress to the patient is that my two children are not talking to each other. The one by the bedside is one child. You talk to that one child, he'll say, yeah, that's because my sibling is, you'll get one litany of complaints for the last 10 years. They never hear, they never do this. I'm the one who's doing everything. So why should we call him now? It's a property issue. Now he'll show up because my father is dying. So he wants the and there is this sort of barricade that happens. But unless we talk to that other sibling, we're never going to know what the full picture is. Now, our goal at the end of it is to lower the distress of the dying per patient or the sick patient or the family as a whole, to alleviate their suffering. Sometimes palliative care requires us to also facilitate conflict resolution. This patient is not going to respond to pain medication unless his children start talking to one another or there's some sort of breakthrough or some sort of closure. Which is why we also very often take on the role of becoming these conflict resolution, facilitators. And for that, this is something that it's very easy to take. I'm not saying, my language is failing me at the moment, but this is not to say that we don't trust what the caregiver or the patient is telling us. All I'm saying is that that is only one side of the story, and it is important for us to really get a larger picture from more sources. And who are these other sources? Like I said, we also talk to friends, we talk to family, we talk to relatives, we talk to neighbors, and home visits. Why are home visits such a major source of information for us? Because that really tells us the living conditions of the person. Okay, where in the house is the patient kept? Are they kept in a room by themselves where nobody talks to them? Or do they have ventilation? Do they have light? Do they have access to a toilet? Is it a place where they get natural sunlight? Is it a place where they're just left for the day, even if they're comfortable, but all the family members go out to work, so this person is on their own for most times? In some cases, we see there are two elderly people living together. One of them has a serious condition, the other person has a mobility issue. Who is helping them with the compliance with medication? When they're running out of medication, who is getting them a fresh stock of medication? Are they missing doses of medication because they're unable to do this for themselves or for each other? You have your hand up, Sonalini. You want to say something?
Yeah, I just had a very quick question. Your slide said you would get information from neighbors. I was wondering how that works. Isn't that very sensitive in terms of how do you deal with the confidentiality issue or the fact that the family may not like that? I'm just wondering how it actually pans out.
Thank you for pointing that out. That's not so much for personal information about the family, but it could be for for economic stuff, like the family has applied to the panchayat for help with house repairs, but there has been no support on that front. Maybe neighbors have also had the similar experience. So the neighbors part comes in only primarily for more socio-economic information, not so much for family and personal information. Sorry, I should have clarified that there. Does that make sense? Yeah. Okay. So
I think sometimes when you say neighbors, sometimes the neighbors know more about your situation than the others.
yeah,
no, I'm being honest here, because there may be an alcoholic in the house. There's a problem. Like not every household has problems, but you'd be very surprised how much the neighbors know, actually.
It's true. And as much as I would like to, honor and respect, and I do, the confidentiality issues, like you said, in a lot of our communities, the neighbors do know. Like, it's a simple thing of, this guy comes home drunk every evening and beats up his wife, and we hear it. And the family is too embarrassed or ashamed or scared to talk about it. Now, I'm not going to go nose around and see, if I can get information like that out of the neighbors. But there are certain situations, especially with extremely impoverished families, where really to piece the whole picture together, we do take a walk around the neighborhood. And people just come up and say, oh, thank God, finally there's a team that's come here to this family's house. And this poor lady, she just lies there on her bed with nobody washing or cleaning her for days on end. So it's really nice to see that a team is now here. So very often that's the way the information comes out as well. I'm just going to check the chat box. Sometimes a neighbor accompany the patient with, yes. And this is a very important point, because sometimes it's the neighbors who have to look after the younger members of the family when the older spouse or the caregiver has to take the patient to the hospital. And very often, the children, when we're exploring how the illness has impacted children, it's their other carers who will tell us, yeah, he's been acting out lately. He was not such a naughty child, but now we can see that he's getting involved in all these, like, he's hanging out with this gang, or he's cutting school, or he's doing these kind of things. So anyway, not to prod and probe, but they are sources of information. I'm going to move along now.
May I share something very short?
Please.
Yeah. Okay. So this happened, I think last year during COVID, when I was working as a resident in the Geeta Medical College, Visakhapatnam. So I was accompanying the psychiatrist. So there was a emergency call from the ICU saying that there's an old man who is complaining of psychosis symptoms. So finally, when myself and the senior psychiatrist, both of us went and saw the patient. Eventually, what we figured out is that he is having discomfort from the morning because his leg was amputated and he was restless. Because at that point his diabetic levels were high because they had to amputate his leg. So that is the main complaint, but not psychosis. But people, I think including the nurse, staff, everyone interpret it as the psychotic features and nothing. It's only the discomfort, and he's having some, is not able to communicate properly with the nursing staff. And those people also couldn't communicate to him in turn or something. So that is the issue. But everything was kind of miscommunicated, and because, yeah, this is what I mean we observed. Thank you.
Thank you, Ravikant. I think there's something to be said about the bias towards our training. If I'm trained as a psychiatrist, I'm going to look at a thing through a psychiatric lens. If I'm trained as a psychologist, I will look at it through a psychological lens. A doctor will look at it through a medical lens. We have to be very careful not to label our patients through the lens of our treatment. Does that make sense? Because I remember as a psychology student, we go through this thing called the Dunning-Kruger effect. The less you know, the more you think, the more confident you are. And the more you learn, you realize how little you know. So it's called the Dunning-Kruger curve. And as a young psychology student, my God, I thought, wow, I know so much. And there's a tendency then to label everybody. Oh, I think this person is bipolar. Oh, I think, they fit this category. So we have to be really careful about not applying the lens of our training to everything. Sometimes, like what you said, this person's leg has been amputated. There is something called the phantom leg syndrome as well, right? And so it's not psychosis. It's something completely different. Thank you for that, Ravikant. Thank you very much. It's really important to get out of our boxes and look at a story through a fresh lens. So we talked to somebody here also said, I'm so sorry, I forget who exactly said it, but assessment is an ongoing process. It is not a one-time thing. We are constantly going back and assessing, reassessing. And as the person's disease or illness trajectory changes, we have to assess them at every point. And as the psychosocial needs of the patient and family caregivers often change over the course of the illness, we need to keep going back. And each time, it is purposeful observation and purposeful conversations. I sometimes hear young interns saying, yeah, I went and I sat with this person and they ventilated their feelings. That makes no sense to me. And with all due respect, it does not make sense to me, because we are not here for just a random conversation to show support. Everything as clinicians who are in this line of work, to be able to help somebody, not help, but assist them in alleviating their distress, we have to measure our words. We have to think about why we are asking them what we're asking them. Why are we asking them for such personal information? If it's not to, like I said, continue to piece together this jigsaw puzzle. Okay. So when I hear stuff like, I went and spent half an hour with this patient, and what was your conversation about? Oh, she just ventilated her emotions. I want specifics. Did it help? In what way did it help that person to say these specific things to you? What are you going to do with that information? We're not here to just, gossip. So what are you going to do with the information that you asked for and this person gave to you? Yeah. And we're looking at what are the important areas to be assessed from the point of view of total pain. So let's just quickly go through this patient and family overview, insight about the diagnosis, and I'm going to take you through each of these very quickly. Insight about the diagnosis and prognosis, family structure and dynamics, socioeconomic background, psychological status, spiritual sense of well-being, psychosexual issues, and finally the interventions and a plan of action that you are going to create based on the information that you can get. Now, again, we're not aiming to get all of these categories at the first conversation. This is an ongoing process. So depending on what is absolutely needed in that moment, you will ask for that information and elicit those responses. But these are the broad categories that we are going to try and cover in the course of our relationship with this patient and their families. And these are the areas we're going to go back to constantly to see where they're at in order to reduce their overall distress. Yeah. So patient and family, first of all, please get basic demographic details. Who are these people? Where do they live? Where do they come from? Are they from this town? Occupation before and after the illness, because that makes a big difference. What were they doing before this disease was diagnosed? Not just the patient, also the caregiver. Are they still holding on to the jobs? What has changed? And this is also important from the point of view of the sense of self that the patient has. Today, if I were to ask all of you in this room, who are you? Who are you? How are you going to introduce yourselves? What will you say when you introduce yourself? Hi, I am so and so, and I am a doctor. What else? How will you finish that sentence? I am.
I'm a social worker.
I'm a social worker. Yeah. Mother and a clinical psychologist. So see, the roles we play and who we identify as, a lot of it has to do with what we do, right? You get diagnosed with a serious disease, that role is gone. Then who are you? Who are you then?
Healthcare provider.
Healthcare provider. Yes. Now you can't go to work anymore because of your illness. Then who are you? If you're no longer providing healthcare. A patient, that is, oh yeah. Unfortunately, that's what we reduce people to. And not just the healthcare system, even we as loving family members, we do that, right? But it's important to know why, because so much of what you're going to get to know about this person will have to do with how they spent their time before they got sick. If I spent majority of my time providing care to other people, found joy in that, that was how I paid my bills, that's how I identified as, it's going, you know a lot about this person. So knowing the occupation is important. It's also important from a practical point of view. Have they lost income? Has a 2-income family become a 1-income family? How has that impacted the rest of the family? Okay, so these demographic details are important. Where do they live? Do they have enough food, water, shelter? If they don't have that, then we can't even, talking about medication and procedural interventions is a different thing. So coming back to this, demographic data, what they did in terms of occupation, who is the primary caregiver and what is the relationship? By primary caregiver, I mean the person at the bedside. Not the person making the decisions, but living in another city, the person at the bedside. It could be a hired caregiver, it's fine. Okay, then we also need to know who is calling the shots in terms of the financial expenditure. Okay. One. So that's something that you need to know right off the bat. This is information that we have to know right off the bat, because even if we're going to do pain management, we need to know who is going to be there to administer the care after the pain management regimen has started. Okay, insight, very important. Now, by insight, I mean, how much does the family know and understand of these three things: diagnosis, prognosis, and palliative care. Okay, now diagnosis, prognosis, and palliative care. Why do I need to know how much the patient and the caregiver know?
Your line of communication depends on what they already know.
Okay. And is there a difference between knowledge and insight? I know my diagnosis, but I don't understand it. How many of you knew what buccal mucosa cancer meant?
I just Googled it when you mentioned.
Okay. All right. Okay. So let's just take that. Buccal mucosa. So what was it, Priyanka?
I saw images of the cheek and I thought, is it oral cancer? I didn't understand.
So I know I have buccal mucosa cancer. I have no clue what that means. The family knows the diagnosis. And this is the thing. Families will pick up the vocabulary of cancer like that. Not just cancer, whatever disease. If it's a motor neuron condition, I've had families throw tongue-twisting medical jargon at me. But do they know what it means? I had to look it up myself. It's cancer of the inner cheek lining, which falls under the larger category of head and neck cancers, which is a disfiguring cancer. The highest suicide rates amongst people with cancer are people with head and neck cancers. I need to know these things because that's where this is going, or it could go, right? So insight on the diagnosis is, do I know what the diagnosis is and do I know what it means? Do I know what it means in terms of lifestyle changes? Do I know what it means in terms of the sacrifices I'm going to have to make? Do I know what it's going to cost? Knowing the diagnosis and understanding the diagnosis are two very different things. Okay. Similarly for prognosis. I might know the diagnosis, but I don't know the prognosis. Prognosis is what is going to happen. What is the likely trajectory of this illness? In our culture, very often we hide the prognosis from the patient. Why? In an attempt to protect them. From what? Nobody can give me a straight answer. What are we protecting them from? I often hear stuff like, it'll take away their hope. Their hope for? Does anybody? Future is okay. There is still a future, but we can only know how to navigate the future if we know what to expect. It's almost like, how many people in this room think we're immortal? Anybody in this room think that if we don't talk about death, we become immortal? Or no, right? Death is the inevitable consequence of living. But we don't want to talk about the seriousness of an illness because we're taking away the hope. And when I say, what hope are you taking away? It gets very murky. The thing is about palliative care, you are not taking away hope. You're taking away the hope for futile stuff, but you're reinstating hope for a good quality of life. I need to know what you know about this illness so I can work with you to make the best of it. It could be 10 years, it could be 5 years, it could be a month. But unless we know where we are, I can't work with you to achieve whatever. You might want to go to the park or to a temple for a final pilgrimage, or you want to maybe make it to, somebody's wedding dinner. You might want to live till your daughter's graduation. I don't know what your hopes and expectations are. Yes, Isha, please.
I think although I'm for telling the patients what they have, and insight is good, knowing about the prognosis is good, sometimes I think family members try to hide it because it could be very disheartening. And it's difficult for them to accept it So they're protecting the patient because it's a very stress-provoking situation to be telling the patient. It's going to be very stressful for the patient to accept it as well. So I think from that point of view, people don't tell.
It's true. And I think you've hit the nail on the head. It's oftentimes the fear of the caregiver. I'm afraid of the fallout and what it means for me to manage it. And oftentimes it's, there are families where the head of this family, who has been the strong, in control person, who has been the patriarch or the matriarch of the family, called the shots, raised all the children, made sure everyone had an education. Suddenly we infantilize them and say, she can't handle it. She's handled all of this, but she cannot handle this. It's also at that point I will stop and say, what are you afraid of? Right? Now, I want to be very clear. I'm not one for pushing to tell the truth. It's not always necessary. There will be moments when it is not necessary, or it's far beyond the point where the truth of the prognosis is going to do any good. So I'm not for telling the truth at all costs, but really there is something to be said about exploring the fears that a family has as a whole about, having this conversation about the prognosis. Somebody has said false hope, sense of giving false hope. Now, unfortunately, I don't mean to get philosophical about this, but we have become a death-denying society, and we have become so technocratic in the way we approach mortality and illness that the only acceptable answer to a disease is cure. It's not. And if we are saying that this disease is not curable, but we can ensure that you will not suffer, that is not a conversation we've been trained to have. The only hope sometimes I find that people are holding on to is the hope of a complete recovery or a cure, even when the patient themselves are seeing how much they're declining and how much more frail they're getting day by day. So that is a larger conversation. Yes, Priyanka.
So ma'am, I have a question regarding the patient's awareness about his or her own medical condition. So there is a grandmother in my family who has cancer, and the family is not willing to tell her because they fear if the grandmother comes to know, she's going to manifest death because she will lose hope. So they think if you don't tell the patient anything, you're making the patient hopeful that you will live longer. But if the patient comes to know that they have cancer, they will start thinking I'll die, and they will die sooner. So this is a situation that's happening in my family right now.
I'm sorry that is happening, and I'm sorry that this is so common a phenomenon. And the thing is, I think we need to revisit our understanding of hope. And sometimes it comes down to a very simple question. What are you hoping for? Are you hoping for a long life at any cost? Or are you hoping for a life that allows you to, do certain activities or be the kind of person that you see yourself being, right? I would recommend, if you haven't already read the book, Being Mortal by Atul Gawande. In that, he poses a very important question where he says, what is acceptable to you? What is acceptable to you? And to some people, it is unacceptable to me to have my child, help me with bowel movement. It is unacceptable for me to be dependent and be completely vegetative. It is unacceptable to me that I cannot make decisions for my own. So those are the kind of conversations. Anyway, I think I'm digressing. But what I was trying to say is that just understand that insight and knowledge are two different things. Someone might know their diagnosis and not understand it. Someone might have a general idea of prognosis, but not really understand what the disease trajectory is going to look like. And some people have no idea what palliative care is and why they've been sent here. So understanding that is also important. Like someone said, that will set the foundation for your future conversations. Okay. Coming back to the assessment, what are the areas we're going to cover? Patient and family basic information, how much insight they have. Very important to understand family structure and dynamics. And for this, we have this excellent little tool, which a lot of you are very familiar with. It's called the genogram. I feel like it's a very underutilized tool. Many people say, oh, okay, family tree, big deal. But to me, it's really such a great way to depict the family structure and dynamics, because it personally, I'm a little bit lazy sometimes. So it helps me. It's like a shortcut where I don't have to take too many paragraphs of notes. I just have to keep adding to a drawing. Okay. The genogram or the family tree was something that was created by Murray Bowen. It's a graphical representation of a person's family over at least 3 generations. So there is a tendency sometimes to just draw the patient, the family, and the immediate family, but a real genogram requires you to go 3 generations. And this diagram will tell you about the structure of the family, the dynamics, the strengths, and the resources. Okay, if you do the genogram right, it can give you all of this information. And the types of information that we typically put in a genogram is the name of the person, their age, educational or occupational profession, and the emotional relationship each of those people have towards our primary index patient. Okay, now, typically, these are some of the symbols that we use. You can Google it. There's male, there's female, there's relationship, whether they're married, they're separated, they're divorced. This is some of the like the most common ones. We also have for children to depict children, whether it's an adopted child, a foster child, whether the woman is pregnant. You know, and this is usually when we look at maternal and child health and things like that. These are some of the things we want to see in terms of their family history. It's not necessary for palliative care, so to speak, but you can include this. Very important, a good genogram will tell you the relationships that people have, whether it's just a regular relationship, whether they're very close to one another, where there is a lot of intimacy and that is that person's confidant. This is the person they go to talk to about all their problems, whether there's hostility and, you know, there's some rivalry or conflict between people. Sometimes there's violence between people, emotional abuse, sexual abuse, or just neglect. And these are important things to talk about. Now, typically, if I just draw a genogram without the emotional, you know, relationships, this is what it'll look like. It'll just tell me the structure. So here is a genogram. Who would help? Who would like to volunteer to explain this to the rest of the group? Okay, anybody? Any volunteers?
So basically a family, husband and wife, and maybe that's brother and sister, son, daughter.
There are 2 families here.
Yeah.
So
Take their name.
Kumaran and Laila are wife and husbands, and Mohan and Leela also wife and husbands. So here the first family has one son named Shaji, and the second family has one daughter. So and one daughter, yeah. So they both got married here, Shaji and Sindhu, and they have twins by name Amal and Vimal. So
there's one confounding factor, isn't there?
Sindhu is the patient. Add on?
Sindhu is the patient.
Yeah, go on.
Sindhu is the patient. No?
Yeah,
No.
yeah.
Can I add on?
Yes, Isha.
Sindhu is the patient. She has 2 husbands, Shaji and Raju. With Shaji, she has 2 children, twins. And with Raju, she has 1 son in the 11th standard.
Okay. Still a bit confusing, isn't it? It's only when you draw out the dynamics that you realize what is going on. Okay. Now, would someone like to explain this? Green is a strong bond. Red squiggly marks are a hostile relationship. And strong relationship is blue. Okay. Would anyone like to now unpack this? Okay, in the interest of saving time, Sindhu is our patient. She's living with Shaji. and they're married. We don't really know what happened between Raju and Sindhu, whether they are married, whether they're divorced. Oh no, now we know Raju died. You can see a cross in Raju's box, right? So Sindhu, so here we are, 1 second, hang on. Sindhu is our patient. She is now married to Shaji, with whom she has twins. Shaji is very close to these two. Okay, he has a good bond with them. Sindhu's husband Raju died, but she has a son with Raju, Sharat. And Sindhu is very, very intimately close to Sharat. And she's also very close to her two sisters, Bindu and Indu. Now, Shaji has a brother called Subhash, who is married to Veena, and both of them have a very hostile relationship with Shaji, and Shaji has a hostile relationship with his stepson. But these two are sort of apathetic to one another. Vimal and Amal and Sharat, they don't really talk to one another. And these are the 5 people who live together. Does the story make a lot more sense now? Yeah? Okay.
Yes, madam.
All right. So now we know who we can rely on and who we cannot. So it's very important for us to look at the relationship, because what is the current status of the relationship between important people? It tells us who is supportive of the patient, who is estranged, who is isolated, whose relationships are altered by the illness, who no longer come around because, maybe they're worried that or they've already financially helped out the family, they can no longer afford to do it. And Jacqueline Johnson says, the disease is isolating, and the isolation can hurt far more than pain. Suddenly you, the person with the disease, is one side of a wall and everyone else is on the other side, the normal side. So the genogram is not just telling us the structure of the family, it's telling us the relationships between people. And I would encourage you to draw out this genogram as you get more and more information about the family. Keep building on the same genogram, because in one snapshot, you have the whole story and everything you need to know. The second thing I'm going to talk to you about is the EcoMap. Now, while most people are familiar with the genogram, fewer people are familiar with the EcoMap. The EcoMap was created by Anne Hartman, and it's a pictorial representation of the patient's family in its social environment and the family's relationship with larger society. And it is a snapshot view of the most important interactions of a patient's family with surrounding systems, groups, extended family, individuals, organizations, and so on. Now, here's the family. And whatever the genogram of the family is, the nuclear family is, every family has relationships externally, with the school of the children, with religious institutions, with the workplace, with neighbors, with friends. And this is where, like you draw a genogram with the dynamics, you place the family in the center and you see what their relationship is with social organizations, institutions, and people around them. Okay, now for example, here is the family of, this is a husband and wife, the wife is the patient, they have 2 children, and here is an EcoMap that we've drawn out, where we know that a straight line is a positive normal relationship, dotted line is weak, and this is a stressful relationship, a hostile relationship, a jagged line. The arrows tells us the energy flow, whether the family relies on them or they get something back from that organization. Now you can see that the whole family has a very reciprocal positive relationship with the church. So the church is a major source of support to the family, the church, their faith, the congregation, so on. There is a self-help group that is a major source of support to the wife who is a patient. The husband relies on his colleagues. They are probably people that he feels relaxed with or relaxes with. The public health center and the wife have a very weak relationship, obviously not accessing the public health center very much. The son really enjoys college, and that's where he gets his sense of replenishment, or he feels relaxed, or he has his friends and so on. Both these children have strong relationships with their friends, and the younger daughter, she's very affiliated with the youth organization. There is a volunteer who comes to the family. The neighbors have a stressful relationship with the whole family. Okay, and panchayat members, it's a weak relationship. Now, looking at this, what can you tell me about sources of support for this family? you as a case worker, once you have all this information, in what ways can you help them access support from their neighborhood? The healthcare system cannot be everywhere at once. Sometimes very often we need to rely on the community to help us support the family. I'm going to encourage you to use the chat box and let me know what your thoughts are. Yeah, I'm going to move along because we have a case presentation as well. Okay. Once we have the snapshot, pay a little extra attention to the caregiver. And I love this line that says there are only 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need a caregiver. And so the caregiver is a role that all of us at some point in our lives will be familiar with. And we need to really show respect to these caregivers, acknowledge them and their complex role, and a simple asking of their name, how are you today? How have you managed this journey will go a long way in establishing rapport. We have this terrible, terrible tradition in our system in hospitals where we call the attendant or the family caregiver a bystander. The word bystander means someone who stands by doing nothing. It is the actual opposite of what a caregiver does, which is to be on the front lines, looking after people. So I personally, if I could launch a campaign to get rid of this word bystander from the healthcare system, I would do it. You have to go into the socioeconomic background of the patient. And this is again gathering information over a period of time. Do they have adequate food, water, clothing, shelter? Who is the breadwinner? Who controls the finances? What is their source of income? Do they have any debts which is causing them to alter their treatment plan? Social support. Is there any social support? And this is where also your genogram will come into place in a very strong way, because can they rely on neighbors for respite? Can the caregiver leave their children with the neighbors? Can the neighbors, come in with medication when they need it? Those kind of things. Does a school understand the difficult time that the family is going through, and will they make allowances for the children? So those kind of things. Has the education of the child been disrupted as a result of the illness? Psychological, we have a whole session on mental health in palliative care, so I will not get into it right now, but understanding how distressing this is to the patient and the family. What are their needs? Are they experiencing anticipatory grief when as the person gets more and more seriously ill? What are their coping mechanisms? It's also important for us to realize that, and Isha and those amongst us who are psychologists know this, that any dysfunction that existed in the family before the onset of a crisis like an illness is only going to get worse. It's not true that a family will suddenly rally together and just become very cohesive. The fault lines that existed in a family before the crisis of illness hit are likely to just get worse. The kind of coping mechanisms people had before the crisis are likely to get amplified. So different people in the family will have different coping mechanisms, and that will impact the overall experience of well-being or lack of well-being in the patient. Spiritual assessment, we're looking at 4 kinds: connection, strength and comfort, hopes and concerns. And I'll share with you a spiritual assessment tool that has really helped me understand this better. And it's a beautiful way of bringing in spiritual concerns into just day-to-day conversation with the patient. So I will share that with you as a learning tool after this session. I would really love to hear your thoughts on that spiritual assessment tool. So maybe the next time we have a session, we can spend 5 minutes on how that tool, how effective you think that tool would be. Psychosexual assessment. This is very, very difficult because we don't like to talk about sexual issues. We don't like to talk about them. And how are you going to assess the distress caused by sexual intimacy? Now, for instance, we have a lot of patients who had some sort of spinal cord trauma, have been wheelchair bound, young couple. This has happened, just soon after the wedding. And you have a young woman whose arranged marriage has ended in 2 months after her marriage, in her husband being wheelchair bound with no real sexual intimacy. She is now his caregiver for life. Her own needs are not being met. She's likely not going to be a parent. Isn't that a terribly distressing space to be? And no one to talk to, because we don't talk about these things, right? So having that conversation, I mean, that's a big example I'm giving you. But even somebody who is living with a life-limiting, life-threatening condition, they need to talk about their intimacy and psychosexual issues. How many of us are comfortable even entering that space to explore how the disease or the illness has impacted on a person's sexual intimacy? Okay, this is just something I'm going to leave you all with. We can discuss it further at another time. Senior, I'm going to ask you to please be ready to line up the case presentation. Okay. And finally, it's only when we have all of these different facets of information, we're starting to pull these little threads together, that we start determining our interventions. Hey, does this person not understand what buccal mucosa means? Maybe I need to explain it to them and their family. Okay, who can I connect them to in the panchayat, or who can I connect them to in order to make sure that they get their caregiver pension? Do they know that these schemes exist, which will help their financial distress a little bit? Do they know that there is a scheme or a subsidy that is available? No, they don't. Let me liaison for them and get that for them. Do they need supportive counseling? Would they benefit from regular check-ins in terms of just a counseling session? Do we facilitate them getting better food, water, shelter from the panchayat? Very often we find that those are their biggest needs. And the monsoon is coming, there's a leak in my roof, especially where the patient's bed is. How am I going to fix it? I don't have the money for it. So maybe we facilitate repairs for that family. Do they have rehabilitation needs, whether it's vocational rehabilitation, whether it's physical rehabilitation? After the patient, if the patient is close to end of life and the family seems like they're very shaky, they might need bereavement support. How do we plan for that? And of course, regular follow-ups with all of these families. To summarize, assessment is the essence or a working hypothesis. It's an ongoing thing. It is a participatory process. We talk to different people in the constellation of the family. Information can be derived from different sources. Sometimes it's direct information. Sometimes it's information we get by observation, especially when we do home visits. It helps us to identify the impact of the illness, the resources that the patient and the family have, what are their strengths, what are the dynamics within the family, who do we talk to, who is the decision maker. We should be very clear about that. And please note that assessments have to be documented, revised, and updated. We have to be scientific with them. Although there's more an art to gathering this information and putting it to use, in order to make this an effective way of supporting the family, documentation, the use of verified tools, even when we're assessing for depression and so on, validated tools, and to constantly go back to our notes to monitor and evaluate whether our interventions worked. These are very, very important. And that's how we build evidence for better psychosocial care. I'm going to stop with this for now. And remember the case that we talked about right in the beginning, the 55-year-old lady with buccal mucosa that we now know is cancer of the inner lining of the cheek. We're going to go back to this case. It's a real case that one of our social officers has worked on. And through a method of assessment, this is some of the information that has been gathered. And we will use the last 5 minutes to really, as a group, discuss this case. So Ashika, over to you, and let's just quickly go through this case.
Good afternoon, ma'am. Good afternoon, all. Am I audible?
Yes.
You are. Okay, and moving on to the case presentation. Regarding the patient overview, the patient is 55 years old female, diagnosed with CA buccal mucosa in the left side. She's not an employed one. Regarding the medical history, the patient reported with painful ulcer in the left inner lining of her cheek, that is buccal mucosa, to a doctor in a hospital. He referred her to MCH, Medical College Hospital, Trivandrum, for biopsy and further treatment. She was then diagnosed with cancer of the buccal mucosa and started radiotherapy and chemotherapy at the Regional Cancer Center in 2021. Regarding the insight after the first assessment, regarding diagnosis, prognosis, and palliative care, regarding the diagnosis, the patient is unaware of the diagnosis and the seriousness of the illness. Regarding the family, the husband is aware that the diagnosis is CA buccal mucosa, but he's not aware about its severity, how it's spread in her body regarding that things. And when coming to prognosis, the patient is unaware, and the husband is aware about the treatment and medications, but not in a detailed way, or regarding the curability of the disease, he's not well aware about that. And about the palliative care services, or what is we do as part of palliative care, both the patient and the family were unaware regarding the palliative care services.
So I'll just stop for a second here. Can you just go back, please? One thing, this in itself, this one slide gives us a lot to work with. We already know we have our work cut out for us. We're not going to insist that the patient knows the diagnosis and the seriousness of the illness. We're first going to talk to the husband. Okay, the husband, who is the caregiver, knows what the diagnosis is, but as is quite typical, does not know how serious it is, or what the severity is, or what the trajectory is. Point number one, we need to sit down with him. This is a goal for us. We make a note of this and say, okay, this is something that we need to talk to the husband about. There is a lack of information here. Again, we're not going to go to the wife to talk about the prognosis. We're also going to sit with the family first, understand what they understand of the prognosis, fill in the gaps, because at the very least, the family needs to be prepared for this. For this, you have to have a doctor on your team sitting with you for this conversation. Because this is not a conversation that I, as a counselor, can have, or a psychologist can have, or a social worker can have. The family is likely to have a lot of medical questions. So my next thought is, okay, this is what the husband knows and doesn't know. So what we need to do now is, the next time we have a meeting, I need to get the doctor in, and we need to sit and have this conversation with the family so that we can plan steps ahead. They have no idea what palliative care is. So first and foremost, we need to talk to them about palliative care. We're telling them that this is not the end of the line. Palliative care is, so this is what we do. We're here to do blah, 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 etc., etc. We're going to manage your pain. We're going to be doing this. And this is how our relationship with you is going to look like. Over the course of the next few meetings, we're going to be exploring with you areas that you're finding difficult, distress that you're experiencing physically as a patient, and in other ways as a family. And we're here to assist you so that no matter what the illness looks like, we're going to make sure that you're as supported as possible. So this is a way for you to introduce yourself, your team, and what the team does. So please continue, Ashika.
Okay. And after assessment, we include the genogram and echo map. This is the genogram of the patient, and the patient has siblings, and she is the youngest one. She's married and she has a son, and she has two grandchildren. One of her siblings is having a physical disability, and based on relationship, her relationship with the husband is described as very close to the assessment. And two of her siblings have died. This is about the genogram.
Okay, so here again, we're saying that this is the information that Ashika has been able to get over the first one or two conversations. So please note, we don't have the full picture. We don't know her individual relationship with her other siblings. We don't quite know, what the dynamics are, who is financially supporting this particular family unit, if at all. And we don't really know a lot at this point. But again, I'm going to ask the group, what are some of the things that you might want to explore when you're looking at this genogram? I'm just opening this up, Ashika, to the rest of the group. what are some of the things that you would try to fill in terms of information gap as far as this genogram is concerned?
I'd like to know if there is any family history, because so many family members have passed away of any cancer, and how if yes, then how the family dealt with it, and what she knows about it.
Right.
I'd also like to know the support system in the family itself, how their relationships are with each other, and who could be a support system to her and would assist or help in any way to take care of the patient.
Yeah. I'd like to know her relationship with her daughter-in-law and her grandchildren as well.
Mm-hmm.
Anything else? Anyone else would like to know anything else here?
There is a common search for spiritual needs.
Church for, okay, that we'll talk about in the eco map. Within the genogram, so there is a lot of scope for more information here. What about the husband's family? Exactly, great question. We need the husband's family information as well. So this is something that maybe we didn't get around to garnering in the first conversation, but we know that this is a goal of our next conversation, to find out a little bit more about the other side of the family. Is there any support we can get from there? So we've already got a couple of goals in mind, right? We know that we have to educate them about palliative care. We know we need to understand information gaps. We know we need to get a doctor involved in the next conversation. And we know that when we have this genogram, I mean, once we have this conversation, we're going to try and get information about the husband side of the family. Already 4 goals for us as assessors. Okay, please, next slide, please.
Here comes the eco map of the patient, and as we see, the family is having stays as a strong support system for the patient, and other support systems are the panchayat, RCC, where she takes a treatment, and her relatives, and she had a stressful issue with the financiers who help her for financial help.
So I would make one small correction here, which is that at the center of the eco map is not the patient, but the family of the patient. Okay, and what we're really assessing is the family's relationship with the people in their ecosystem. So positive relationship with the panchayat is a good thing. Financiers, we need to know a little bit more about that. Relatives, it seems like a positive relationship, and the RCC seems like a positive relationship. But I would also say that this is our first snapshot. If we, over the course of the next few conversations with them, we need to know each family member's relationship with each of these different systems. So is somebody in the family religious? Do they have a good relationship with their faith-based community? What is the relationship of the parents with the school children, with the children's school? What about the local public health service? Is there a relationship happening there? Why must the family be in the middle? Because this is the eco map. We're trying to figure out where the support system for the family can come from. Suppose, say, a caregiver is really tired and exhausted, but he has a good relationship with I don't know, with some card, you know, he's member of a club. So maybe we can facilitate some time off for him to go and relax with his friends. Maybe, you know, there's a bunch of friends that the siblings have not met for a long time. That's going to be their source of respite. So also in terms of finances, the panchayat, there's a positive relationship. So suppose they're having some issues with basic infrastructure, they can actually approach the panchayat because they have a relationship with them. And if they're too tired to do it, we already know there's a positive relationship. So we will go and facilitate some of that requirement that they have. Okay, please, you can move on.
Moving on to the socio-economic overview of the patient and family. It comes from a poor socio-economic background. They have a BPL card with pink color, and they are having 6 cents of land assigned from the panchayat, but the house construction is incomplete. They currently live in a rented house for 2,000 rupees per month. The primary breadwinners are the patient's husband and son. They are daily wage workers. They are financially drained by the frequent hospital visits. And an important point is that the patient's grandson is a cardiac patient and is under treatment. The family is in debt and also have mortgage of property to Blade Mafia and loans from other financiers.
I'm going to stop and ask, what is Blade Mafia?
And what I meant is that like the financiers who take up more interest for the money and they exploit the customers.
Okay, fine. So this tells us where their financial burden lies. Below poverty line, Isha, is BPL. And you have different colored ration cards depending on which category you fall into. So pink, Ashika, what is pink?
Ma'am, it's like the extremely poor category.
Yeah. So state-wise, Tamil Nadu, Kerala, I mean, whichever state you're in, you'll be able to tell the socio-economic categorization of the family by the color of their ration card. Okay. Okay, next slide, please.
Moving on to the psychological overview of the patient. The patient was once addicted to tobacco and she discontinued its consumption after the diagnosis. Now she's having the feelings of guilt and low self-esteem. She appears in low mood and no psychological support from any other family members to her.
Okay. So very typical. When somebody is sick, we make them feel worse by making them feel guilty for their lifestyle choices, something that just for us to be mindful not to do. So this is where she's at the moment. Next slide, please. I know we're over time. We're just going to give this 5 more minutes.
Assessing the total pain for the 4 aspects of palliative care: physical, psychological, socio-economic, and spiritual. Coming to the physical aspects, she's extremely underweight. She experiences pain all over her body. She faces constipation, nausea, or vomiting. And regarding the psychological aspect, she's in low mood, stressed by the illness of other family members. She's having poor self-esteem and fear and uncertainty about prognosis and palliative care, distress due to multiple issues, and anxiety about the future. Regarding the socio-economic aspect, there is loss of wage due to the caregiving duties by the breadwinners. It further impoverishes the family. There is no proper housing, threats from the financiers that I have mentioned, and the financial instability. Spiritual aspect, extreme spiritual distress, like why all this suffering to me? And there is no entertainment or relaxation aids for her. Cannot recall memorable moments or joyful events in her life, loss of connection with the family, depleted faith in God.
Okay, so what I'd like you all to look at in this slide is, this is a snapshot giving you various different ways in which you can engage with this family. It's literally like a checklist of things that you can work on. If palliative care is the mitigation of serious health-related suffering, here is your checklist of things that you can start with. Some of you might want to go right for the psychological aspects. Some of you might want to work with the socio-economic aspects. Some of you might want to work with the physical and the spiritual. This is why palliative care is a multidisciplinary team. When you understand that these are the aspects that are causing this person the biggest amount of distress, you work together as a multidisciplinary team in tandem to start crossing out points in each of these boxes. The doctor will come in and start taking care of the pain, the nausea, the medical social officers, social workers, and volunteers will help with socioeconomic issues. Counselors will come in and work with psychological issues, and anyone on the team really can sit down and talk to them about spiritual issues using that spiritual assessment tool, working with them at that level. So this is why assessment in these 4 quadrants is important. It facilitates an interdisciplinary approach. It gives you very tangible areas to start working with the family. Next slide, please.
These are the discussion points that can be discussed based on the patient's story. how would we prioritize improving quality of life in terms of physical and psychological aspects? Some practical methods of support are the following: facilitate cancer pension. Regarding that, we must be assessing that whether we have this where we live, and vocational rehabilitation for income generation. We must be generating thoughts and assess the patient for that, and linking the patient with her district facilities for palliative care. And we must having the knowledge regarding the facilities that are available in that given area.
And these are questions for everybody in this group. How many of us are aware that in our state, there are certain pensions available, not just for patients, but for caregivers? This is something for us to go back and dig around and think about, not just cancer, but any illness. Is vocational rehabilitation part of palliative care? Should it be a part of palliative care if to generate additional income reduces the financial distress and therefore the overall total pain of the family? And do you know of palliative care services in your area? I can link you, Senior, can you just put in the directory, palliative care directory from our website into the chat box? This is a comprehensive directory of services across the country, which will also tell you things like where morphine is available and not. So you can stop sharing screen, please. I really apologize for going over time. We're 7 minutes over time, but I'm just going to open the floor up now for a few minutes. We looked at how somebody who is a 55-year-old woman comes in, and we have this basic assessment that we do. At the end of this assessment, these are the stories. This is the beginning of the story that we're trying to piece together, what you saw in those 4 quadrants, which in turn have given us tangible points to start from. This is a story that we will keep building on as we continue to interact and engage with this family. We might find that there are different ways in which we can support them. There are ways in which we can mobilize better care for them. We don't have to do everything ourselves. Looking to the community, looking to the social support system is very important. So very quickly, closing thoughts, closing reflections, and questions, if any.
I wanted to know if we will have access to the genogram where we can write the relationship thing page, given if you can give that to us.
Yeah, absolutely. I would also
make it so much easier for us to have so much information.
The genogram, you will have this entire slide deck. The genogram is, there's lots of examples available on the internet. Okay, depending on your setting, you can adapt the genogram. So like I said, for people working in maternal and child health, for people working in HIV care, for people working in cancer settings, etc., there are different genograms available. The difference is mainly in the symbols that are used or the addition of various other elements. One thing I will urge you to do is whatever genogram you land on, make sure your entire team is reading it the same way. And it's not, genogram is not just for counselors and social workers. I believe that every doctor and nurse on the team has to be able to read the genogram and keep adding to it. That is the illustration of the story. It's going to save you pages and pages and pages of writing. Okay, so make sure everybody in your team is educated, they're following the same symbols, and over a period of time, you'll find a lot of cohesiveness in the team, and people, every time they go out and meet a family member, they'll be able to add that genogram. By the end of it, you have a really rich diagram. Okay, yes. Please go ahead, Sonali.
Yeah, just one question, Smriti. We're starting out work in a very challenging area. It's very remote, it's tribal, interior. We have a local from the villages that we put together. We have the social workers and the nurses. We do not have the counselors. So, I mean, the work is going to begin without technically counselors in place. I just want the confidence to know that the team can take on that counseling role with, without necessarily having gone through any advanced training in psychology or counseling. I mean, I'm just a little worried about that.
No, it's absolutely fine. It's absolutely fine. There's something I'll direct you to. It's called the Barefoot Counselor.
Yeah.
Okay,
Yeah,
you
okay.
know that. Okay, so the barefoot counselor is basically this empowering people in resource poor settings to take on that role without having the degrees and the qualifications. I find that, yeah, unless you're doing some serious like psychological intervention, if you just have the basics of communication and some of these skills, it goes a really long way, because let's remember that before this came along, there was nothing. Just to facilitate these conversations, get people to open up, talk about their issues. Very often, see, our job is not to find the solutions for them. It's to facilitate them to find their own solutions, and wherever necessary, bridge those gaps. So by all means, I think, don't worry about that. I really don't think that should be a major barrier in providing social support. Sorry, there's a question there from Saima. Sorry, did I answer your question?
Oh, yeah.
We can talk some more about this later also.
Yeah.
How do we decide whether to tell patients of their prognosis? If their family is not willing, we don't tell them. Like Senior said, we have a session on communication where we'll specifically talk about collusion, which is what families do, not wanting the medical team to tell the patient. And we will be talking about breaking bad news and having breakpoint conversations about serious illness. So we will stop there. Thank you very much for being patient for an extra 12 minutes. Have a great Wednesday evening and see you next time.